All right, everybody, we're back. Dr. Wright here to talk about left ventricular assist devices.
Good morning, everybody. This is kind of an unusual setting here, so I apologize if it seems awkward because it is awkward for me. And I had an updated version of this where I actually had the correct date, and obviously I don't have it here, but it's the same. So I apologize if you were in on my presentation last year. There's not been a lot of new information added, so this is going to kind of be a repeat. But if you're like me, if you don't repeat something over and over, you're not going to retain it anyway. So hopefully this will be a refresher to keep it kind of in the forefront of your mind so you don't forget about these devices. So we're going to talk about left ventricular assist devices, and my video won't work, so I'm going to try to just skip over it. So what's the importance of these? There are currently about 9,000 of the left ventricular assist devices among the different companies that are being placed per year. And up to this point, just the HeartMate 2, which is one of the devices currently available, there's been about 26,000 that have been placed. And the reason why the numbers are going up is because from the beginning, the original version to the current version, there's been a lot of pump technology improvements, and the adverse events associated with it have also decreased due to us learning about what problems are going to develop and trying to prevent those before they happen. And then overall, they've expanded the indications because it's such a good device. So at this point, a lot of people who have a left ventricular assist device placed go take themselves off of heart transplant lists, because once they go through this surgery, and it is a big surgery, they feel so good with the device in place that they don't want to think about going through another heart surgery, and so they just choose to live the rest of their lives with the LVAD. So there's greater than 5 million patients currently suffering from heart failure across the world. That's not just in the United States. And there's about $32 billion spent annually to treat this disease. The mortality rate at 5 years currently still sets at 50%, and this can be abated with the assistance of an LVAD. So there are some contraindications, people that are not candidates, even if they have bad heart failure. And the first one of these that I want to talk about is right ventricular dysfunction. In order for the device to work appropriately, the right ventricle has to pump good enough to fill the left ventricle for it then to have blood to push throughout the body. So at its onset, if your right ventricle doesn't pump well enough to fill for the preload in the left ventricle, then you can't have the device placed because it's never going to function properly. If at the onset of your disease you have acute cardiogenic shock and you have a neurologic deficit, that is a contraindication. There are several terminal comorbidities that obviously, for obvious reasons, they're not going to put you through placing an LVAD to try to sustain your life. If you have a bleeding abnormality prior to getting one of these devices, you're not a candidate. There are some anatomical factors that come into play. One of these is if the patient has a large VSD, then this device cannot be placed. And if they have a hypertrophic cardiomyopathy, it can't be placed either. And then interestingly, if you're too small, you can't have the device placed. So we think a lot about obesity, and that's usually a contraindication to things. But in this case, if you are a tiny person, you're not going to be able to have one of these devices. And then they actually do a lot of social considerations when they place these, because obviously it's an electronic device that is supporting your life, and if you don't have good social support and the IQ to be able to respond to what the machine's telling you, then they're not going to be able to place this device either. So let's just take a brief look here in a minute at the different parts of the device. So there's an inflow and outflow cannula. There's the actual pump mechanism itself, the drive line that comes from the pump outside of the body, to the controller, and then the external power source. So this is just a caricature of what a patient will look like that has an LVAD. And I can't find my pointer, and I switched the screen. So basically, you can see that the device is in place there at the base of the bottom of the patient's heart. And you can see the inflow cannula going up to the aorta, or the outflow cannula going up to the aorta. The inflow cannula there at the base in the left ventricle connected to the actual pump itself. And then that wire coming off the pump comes outside the patient's body and is connected to the external controller, which gives you all the information about the operation of the device. And then usually has 2 battery sources, and they're kept on either side of the patient, and they wear this jacket type thing that holds all of it, and usually carry extra batteries as well, or at least you hope they have those. So in general, the first generation pumps, and this is part of how the improvement has gone, they tried to develop them to be pulsatile. So when the patient's heart would pump, the device would pump at the same time, and they tried to correlate that. And then they gave up on that, realizing that it was better to just have a continuous flow device. And one of the reasons for that is because they were able to limit the contact of the blood with any part of the mechanics of the device that might crush the blood cells and cause further issues. And like I mentioned earlier, currently there are 3 on the market, the HeartMate 2 and 3, and the Heartwear. We'll talk about those individually. So this is an example of the HeartMate 2. And again, these are all going to look kind of similar in their setup. And so the long pipe that you see going up to the top of the screen is the outflow cannula that will be connected to the aorta. The bottom is the inflow, so that's the part that's drilled into the base of the ventricle. And then that's the actual motor there at the bottom. And on this next slide, you can see that this is placed in the abdomen in this case. So this Heartwear, or no, this is the HeartMate 2, and this, yeah, it's the HeartMate 2. This one is placed in the abdomen. The other 2, the actual device is placed in the thorax. So this is just what it's going to look like on chest x-ray, which obviously you guys don't see for the most part. But you'll notice the size of the heart, right? Because usually a failing heart is bigger. And then on the top, you see the pacemaker / AICD. And most of the patients will have one of those along with the LVAD device. This is an example of the HeartMate 3, and you can see that it looks very similar, although the pump looks substantially different. The setup is the same. And now you can see in this x-ray, again, you have a pacemaker AICD in the top left of the screen, and you see that the device itself, the HeartMate 3, is actually within the thorax. So one of the improvements in these devices is that they now no longer have to open the abdomen as well as the chest. They can simply open the chest, and I say simply because it's not my chest, but they can open it and put everything within the thoracic cavity and not have to enter the abdominal cavity as well. And so here is the Heartwear, and this is just kind of a breakdown of what's on the inside, and the next screen will do a better job. If I can get the video to play. I forgot I had a video. Hang on, let's see if I can get it to play. I don't even see the cursor. Oh, now what do just this, right? Yeah. Okay. No, I don't see it. Oh, there it is. Try to go in the middle. It should be.
It's backwards. Okay. No.
Sorry, guys. This is a good video if we can get it to play. You might just go online if you're interested and Google this device and kind of watch this. And basically what this shows is just how the blood is pushed through the device without anything actually physically disrupting the cells, well, as little as possible because of that impeller device and not the pump like they originally had devised. And then here again, that one is just in the chest, so no longer having to open the abdomen. And again, you see the pacemaker AICD in place. So when we talk about managing these patients, the LVAD centers, which the only one I know of currently that's here is in St. Louis, and they recommend that all of the, basically the services where you might come in contact with an LVAD have written protocols. I know we don't have one at the hospital, but it just makes it easier for anybody who is encountering one of these for the first time to give them a little bit of comfort level. Obviously, you guys work off lots of protocols, and so it's a good idea to have a protocol in place on how to treat these as you see them in the field. One of the most important things is that you're going to want to contact the coordinator, and probably for you guys, that's never going to be an issue, but they may actually be on the phone with their LVAD coordinator when you guys get to the scene. And don't discount anything that the family tells you or what they're relaying to you from the coordinator, because they know how to treat these patients obviously better than we do. And so any information that you might get from them could be helpful, not only for you while you're caring for them, excuse me, but for us once you transport the patient. So there's an intrinsic pulsatile flow, obviously, if we still have a pumping heart, but that is not the majority of what is supplying blood flow to the body. So being able to capture a blood pressure on them is substantially different than the normal beating heart. So you're going to have to do that with a mean arterial pressure, and you're probably not going to be able to do that with the regular sphygmomanometer. You're going to have Doppler. So for you guys, it's going to be a great challenge because obviously you guys aren't walking around with ultrasounds on your truck. But we'll not be able to play this video to show you how to do that. But basically what you do is you put the cuff on as you normally would. You put the ultrasound over where you would normally put your stethoscope, and you pump it up, and then you release the cuff. And the first whirring that you hear through the ultrasound is going to match up with the patient's mean arterial blood pressure. So it's kind of an awkward thing that we don't normally do, and obviously you guys won't be able to do that, but that's the best way to monitor these patients' blood pressures. And they recommend that their maps be, it depends on who you read and which device you're looking at, but somewhere between 70 and 80 should be their mean arterial pressure. And if it's anything over 110, then those patients are considered to be hypertensive. So when you examine the patient, what's going to be different? There's going to be a constant whirring sound, a motor sound, and this can impede your ability to even hear lung sounds to a certain extent because it's pretty loud and it's very unique if you've never heard it. Again, they probably are not going to have a pulse that you can palpate with your finger. It's going to be so faint that most of us aren't going to be able to pick that up. So you're going to have to rely on just the fact that they have distal perfusion, i.e. they have good cap refill. And then there shouldn't be any volume overload present in these patients because the heart failure should be under control with the left ventricular assist device in place. So if they have signs of JVD or ascites or something like that, that could indicate that the pump has already failed or they've developed a new problem such as right ventricular failure. And then just know that these patients are at an increased propensity to bleed because, as we'll talk about later, they are all anticoagulated. They're usually all on baby aspirin as well. So they're on Coumadin and aspirin, and they could be bleeding from that, obviously, especially if the Coumadin level hasn't been appropriately controlled. this EKG is going to come up. So when you look at the normal EKG for an LVAD patient, it's obviously not going to look identical to the normal PQRS that you would see in a patient, but it's going to have some similarities. So basically what you're going to see is what's called a splintering of the QRS. Oh, yay, it came up. So that's what's pictured here. So it's not going to be artifact across the entire screen, or it shouldn't be, due just to the device. And the first time I encountered one of these patients was in the emergency department, and I had obviously heard about him, but I'd had zero education. So the patient came in complaining of just generalized weakness, not feeling well, and she kept saying, my PI is low. We're going to talk about that here in a little bit, but to me, I was like, oh my goodness, I don't know what to do this lady. I don't know what the heck PI is. Let's get her on the monitor. So we put her on the monitor. I look up at the screen, and lo and behold, it looks like she's in torsades. But she's sitting there talking to me. And so in my brain, I'm thinking, this is just artifact, right? From the mechanical device that's in her chest, making her heart, functional. So I looked at somebody in the room and I was like, hey, go grab an EKG machine. So they bring it in and hook her up, and I get the real 12 lead. And lo and behold, still looks like torsade in every lead. I excuse myself from the room. I walk out. I call one of our cardiologists, plead my ignorance, and say, holy crap, I have this LVAD patient and it looks like she's in torsades. And he said, Alicia, if it looks like she's in torsades, she is, and you need to shock her. And at that moment, my heart dropped out of my chest. And I thought, this woman is never going to let this dumb ER doctor shock her. She's going to fight me tooth and nail. And thankfully, this cardiologist was in the room about the time that I came out of the pod, trying to compose myself to go tell her that I had to shock her. And we proceeded to, he proceeded to tell her, and she agreed, and we subsequently shocked her. She converted into a sinus rhythm. Lo and behold, her PI went back to normal, and we quickly got her in a helicopter and flew her to her LVAD center. But she was much more stable when she left. So don't let this fool you into thinking that if you see a ventricular arrhythmia on the EKG or on your monitor, it probably really is. So again, these patients are going to run an INR of about 2 to 3. Oh, let me go back to the ventricular stuff for just a second. So just remember that the reason why you want to terminate the ventricular arrhythmia is because, again, the right ventricle has to fill the left ventricle for the device to function properly. So it's actually pretty amazing that this woman that was in torsade had enough preload in her left ventricle for the device to continue working, because in my mind it seems like she shouldn't have had enough preload to fill the device to keep it functioning, but she was. So you treat it with electrical cardioversion just like you normally would, and usually amiodarone at the same time, to hopefully prevent a future event before you get them to the LVAD center. Okay, so again, these patients have a propensity to bleed. They're on aspirin. Their INR should be somewhere between 2 and 3. But as we all know, patients have difficulty with the old-fashioned Coumadin. There's so many things that affects it. So they could be low and they could be clotting, or it could be a high INR of 7, 8, 9, and now they have an extremely high propensity to bleed. Cardiac enzymes should be normal. Again, not something you guys are super concerned about in the field. BNP should be normal because there should be no release of this with the device in place and the right ventricle functioning. And then LDH just can help you determine if there's a thrombotic event that's occurring. So obviously, with any mechanical device or anything that we put in our bodies, there is a slew of complications that can ensue. And these are just divided into ones that are associated with the device specifically, and then ones that are just associated with having all the things going along with the LVAD. So we'll talk about these individually. So GI bleed is probably one of the most common complications, and this is multifactorial. Again, we've already talked about the aspirin and the Coumadin. We've said that multiple times. But when you don't have the pulse of the beating heart, so the up-down fluctuation in your blood pressure, in your vessels, it actually sets you up to form vascular malformations, i.e., AV malformations that have an increased propensity to bleed. So patients that have GI bleeds, a lot of times that's already what caused their GI bleed. Well, now you've set this patient up to actually develop those at a quicker rate than the normal population because you've taken away the pulsatile flow of a normal beating heart. And then interestingly enough, they can develop another bleeding disorder on top of the fact that they're on Coumadin and already on aspirin. And this is acquired von Willebrand factor disease, which is one of our clotting factors. And this simply is a product of the multimers that make up the von Willebrand factor can be injured, and they're slow to renew themselves. And so eventually you run out of von Willebrand factor and cause a clotting disorder associated with that. So obviously all of these combined can set you up for GI bleeding severity. Then stroke is one of the other big complications, and this can either be hemorrhagic for the various multitude of reasons we've already talked about, or embolic. And it's interesting to think that these patients could have an embolic event, but again, their Coumadin level, their INR may be low because they're not appropriately anticoagulated, and you have the heart that's already failing and not pumping the blood through appropriately, and anytime the blood is not flowing has a propensity to clot, right? So that heart that's just sitting there barely moving the blood is not getting all of that blood mobilized and pushed through the heart like you hope in the normal setting is occurring, and so they can form clots. And then also their baseline heart rate may be atrial fibrillation. And we all know that that is the same concept, right? The blood's not being pushed through, you're not pushing it all out and keeping it in constant motion, and that sets you up for clot formation as well. So these patients, the target mean arterial pressure, again, is somewhere between 80 and 90, maybe as low as 70. They take aspirin, and they try to keep the INR below 3, all getting this fine-tuned process, hopefully, to avoid the embolic stroke and the hemorrhagic stroke at the same time. So device-related infections at the onset were one of the biggest feared complications, and they've done a lot to improve that over the years. In the first trials that were done, the infection rate was as high as 50%, and currently there's still a 20% incidence in the first year, but overall that rate is down to as low as 10% depending on who you read. And the most common is going to be staph, and again, it's going to be associated with that drive line where it's coming out of your chest or out of your abdomen and exiting the skin. Obviously there's a pathway for infection to go through that and get inside. And so for evaluating these patients, they're going to have sepsis just like any other patient, and we're going to treat that the same as we would, but in the department, in order to look for the source, you might have to get a CT of the abdomen just to look for a pocket of pus surrounding the device or the drive line as it exits the body. So complications that otherwise that can develop is you go into this with a bad heart, right? But they've checked your right heart and said it was good. Well, now you've had the device for a year and your right ventricle starts to fail. And this can occur in up to 20% of patients. And again, the BNP is going to be elevated. They're going to be in cardiogenic shock. And we all know we treat that with inotropes like milrinone or dobutamine, so it's a little bit different than our sepsis treatment, right? We're not going to expect you guys to be able to differentiate that in the field, but just for your knowledge. And then there might be a variety of alarms that are occurring due to the failure of the right ventricle. Again, we know that you have to have that preload develop in the left ventricle in order for the device to function properly. And when that right ventricle starts to fail, the blood flow is decreased and you may have a low flow event causing issues with the device itself and the function. So let's talk a little bit about the parameters of the devices themselves. So in all three devices, HeartMate 2 and 3, as well as the hardware, you're going to see the speed on the machine displayed, which there's nothing you can do about it, but just for your knowledge, it just is measuring the revolutions per minute of the device itself. And then the power, how much wattage is that device using to function? And those can be, the power can be indicative of an issue within the pump or the heart itself. And then different from the hardware, the HeartMate 2 and 3 display a flow, and that's merely a calculation of the speed and the power. And then also the HeartMate 2 and 3 give the PI, which is what the lady in my story kept saying, my PI is low, my PI is low. In the hardware, you'll have a waveform represented by a delta, so the change from the peak and the trough is what you're going to be looking at in the hardware. But in the HeartMate 2 and 3, the PI is the patient's native pump and the flow that is instilling into the system. So obviously if we have a continuous pump, which we've talked about, right, the LVAD itself is supplying a continuous stream of blood, and then the patient's heart beats and causes the PI to be able to be measured, because that changes the amount of blood that's flowing through the device based on when the patient's heart pumps. So if the patient tells you that their PI is low, that means that they have lost the function in their heart at its baseline when the device was placed. Same for the hardware. If their delta is low, they no longer have the same pump that they had natively when the device was placed. So hopefully that makes sense, because that really is a big part of being able to figure out these patients. So PI low or delta wave is low, the delta is low, means the patient's pump is not the same as it was, their native pump is not the same as it was when the device was placed. So you can have multiple alarms that go off. Some of these will be related to suction events, and that simply will slow the flow through the device itself. And when that occurs, so basically a suction event is if the outflow or the inflow cannula into the device gets stuck up against the wall of the heart or the septum, then it's, basically like you covered it up with your hand and it can't get blood in it. So what does the device do to respond to that? It senses that it's not sucking blood in, and so it decreases the power and the speed, trying to give that ventricle enough time to get enough blood in there so that it doesn't have that suction device again. So that can occur randomly, but usually is related to decreased blood volume overall. Then you can have pump thrombosis, which will cause high flow and high power alarms, and we'll talk about these individually as we go through the next few slides. So the HeartMate simply has two icons that are going to be beneficial for you to look at. So they have a battery light, which if it's yellow means you only have 15 minutes to get that patient plugged in or to their other batteries. If it's red, you only have 5 minutes. So obviously anytime that battery light is illuminated, you've got little time to get that patient to an electrical source. If the heart is red, that means the pump has stopped, which obviously is bad, or it's in a low flow state. And this is just an example showing you where that shows up. I point to it if I could, but you can see on the left side of the device, underneath the battery button is the battery indicator, and then the heart that we talked about, which will alarm to help cue you in, hopefully, to what's going on with the patient. So the hardware only has one alarm signal on it, and it's just triangular. I'll show you on the next screen. And basically it just shows levels of intensity of the alarm. So if it's low intensity, like if there's something wrong but it's not going to kill the patient in the next 5 minutes, it's solid yellow. If it's flashing yellow, that means that they're at medium risk, and if it's red, they're at high risk. So you can see that there right in the center of your screen, the alarm indicator, the triangular shape. And then on both of these, the display will give you all the other information that we talked about, as well as explain what the alarms are indicating, hopefully. So you can have the device itself, if it's starting to fail, you can have failure of the controller itself, which everything I read says has to be exchanged by the LVAD team. So you're going to have to stabilize that patient and get them transported just to get that controller exchanged. Electrical fault is rare because they created a redundant type system that has 6 wires in that driveline itself, so hopefully failure of just one of those wires is not going to lead to failure of the whole system. High wattage from power spikes is usually from pump thrombosis, and then we talked about low flow. That can be because of a suction event or hypotension, volume loss in the patient overall. So for the treatment of these patients, in particular to EMS, yes, CPR is okay. When they originally came out with the devices, somebody erroneously said, well, if we push on these patients' chests, we might dislodge it. Well, they're dead, right? If they need CPR. So take that risk of dislodging something and go ahead and do CPR and give all the ACLS drugs that you normally would. The speed is fixed. If there's a problem with the speed, you can't do anything for it, so you have to do these other things. Defibrillation, like we talked about, is of utmost importance to maintain the patient's native pump contribution that they had when they started. Again, the map should be anywhere from 70 to 90, depending on which device it is and who you're reading. External pacing is just fine, not an issue. You want to make sure that you bring all the equipment with you to the facility where you're transferring the patient, i.e. if they have any extra batteries, if they have plugs, if they have anything at home, you want to bring that with them. And just know that the patients, as well as their family members, are all very well trained. Like we talked about at the very beginning, they are very knowledgeable on what's going on with the patient, what they have to have, and anything that might be going wrong, they might be able to help you. So listen to those patients. A lot of times I know we like to block out others around us because we think that they don't know what they're talking about, but in these cases they're probably going to know more than you are. So make sure you listen to them. So just to recap, ACLS as usual, pulse check's probably not going to be possible. Look at the monitor, it's going to give you a lot of information. Contact their team and plan on transporting that patient to where their LVAD center is, because they're going to need ECMO if the pump actually stops working, the LVAD itself. If it stops working, they're going to need ECMO, because that's the only way they're going to survive. And I guess you can't ask questions.
We can. We're on a
Yeah,
slight
we're
delay.
streaming for questions right now.
Oh, okay.
I'll turn my phone up so you can hear where we're at.
It's going to give you a lot of information.
30-second delay.
Contact their team and plan on transporting that patient to where their LVAD center is, because they're going to need ECMO if the pump actually stops working, the LVAD itself, if it stops working.
Okay, so I have a couple of questions. So with LVAD, so we get our group and we go to take a blood pressure. Are they even going to find one?
Probably not,
Probably
without
not.
the assistance of Doppler.
Right.
Yeah.
Same thing with pulse, right?
Right.
So we're realistically at a BLS level, we're really treating how the patient presents.
Yeah, absolutely. If they're blue and they look dead, they probably are. So I would start CPR. If they're awake and talking to you, you've got time to transport them.
Right. I've always, looking at how the LVAD is attached to the bottom of the left ventricular, and obviously we treat them with CPR if they're in that position. Are there positive outcomes with CPR, or I could see where during compressions the LVAD itself could be displaced.
Right. And that was the initial concern, but they found that in those patients who had received ACLS, now I didn't get into specifically the survival rate, but they looked at the device itself and they didn't find any issues with the LVAD itself after having had CPR.
Oh wow! So I didn't know that because looking at it, you're like,
Right. I don't know that I should be pushing on that.
I know, right? Yeah, absolutely. So okay, well, I know that's just a couple things that we brought up for our personnel because it's a little bit different. I know typically the person there or the patient's family is literally typically a LVAD expert.
Oh yeah.
They know that they got the checklist, they have the equipment, they know what they're doing, and I more than once gone, okay, you're coming
Help me
with
out here.
me.
Absolutely.
Yeah, you're coming with me.
Transporting the patient's family member is probably your best bet.
Yeah.
Yeah.
Excellent.
Does Freeman keep LVAD patients in-house or always send them to?
Negative Ghost Rider, they always leave. If they come in for something simple like a laceration repair or something, obviously we're going to fix it and we're going to discharge them. But if there is any issue with anything, infection, right, because we're not going to keep that patient, because if the infection is in the device, we can't do anything with it. If the device is failing, we can't do anything with it. If their native heart has failed further, we don't know what to do with that. So absolutely, we always transfer these patients.
Where do they typically go?
St. Louis
St.
is
Louis.
the only one in Missouri.
Wow. Okay, I didn't know that. Was there what's the closest? Is Tulsa or Wichita?
I would imagine that they have one, but we, interestingly enough, I've never ran across a patient here that has it. That all of ours seem to go to, a place in Missouri, which is St. Louis, and I think that's due to insurance issues. But
they typically go ground or they go air?
I flew mine.
Is it Barnes they go to?
I think it's Barnes, but
Okay.
Yeah.
They're interesting, but they're very, I mean.
it's a delicate.
I mean, it is.
Yeah. I mean, they're way cool, right? And,
Yeah.
We had one of our local pharmaceutical reps coded one night and got CPR and shocked all the way to the cath lab like 10 or 15 times. He recovered eventually, but with a really, really bad heart. Ended up going to St. Louis, got an LVAD, and made a remarkable recovery with the LVAD itself. He had one of the earlier generations, and he didn't feel like he was at 100% with his LVAD, and so he subsequently went on and had a heart transplant, but saved his life, and he lived to make it to a heart transplant.
So are the LVADs still temporary to, is for the most part, to get the heart transplant?
So as I mentioned, the original goal was you place the LVAD, you put the patient on the heart transplant list, cross your fingers, hope that they make it to the transplant with as few complications as possible. But with the improvements in the malfunctions of the devices, the adverse events, the complications, there are a lot of people that take themselves off the transplant list and say, no, I'm not going to do this, because again, it's a big surgery, right? In the beginning, they were opening their chest and their belly. Now it's just their chest. I've never had my chest cracked. Pray that I never do. But I can't imagine feeling good with a device in my chest that was very painful to get there and then saying, oh yeah, let's just take that out because I want a heart now. I mean, I don't know at what, like, where in your life are you at? I think that makes a difference too. So
Absolutely. That was the questions I had. I appreciate it. Thank you.
yeah, sure.
Any other questions?
No, sir.
All right. Well, thank you everybody for your time.
All right. Thank you.
Thank you
Well, I got
very
a
much,
question
Dr.
as we're talking. Let's go way out there and let's talk. No,
Are we
Let's-
still on?
yeah, no, we're still on. Let's talk
You want it on?
ice storm, power outages, and time frame for battery usage. What kind of
I don't know what the life of the battery that they carry on them is. I know that they do have external connectors, but then you have to have power at the house, right?
Right.
So you hope that these well-trained, knowledgeable individuals have 2 good batteries associated with the device already and 2 that are ready to go in their little fanny pack or
Right.
whatever they've got with them.
And I bring it up because it's kind of funny, but we had an ice storm in 2007 in Broken Arrow, and we went at day 7, day 8, we start running oxygen to people, we start running food, the things you don't think about, batteries. We had an LVAD patient that Well, we stayed in contact with daily, making sure that we ended up actually finding a generator to place they could charge their,
Right, right.
you know, just it's kind of outside the box kind of thinking.
Yeah.
So
After the tornado, we had
Absolutely.
patients with home ventilators that came and plugged in at the hospital because we were the only place that had power.
absolutely, that's
So.
right. So,
Yep.
all right. Well, thank you very much.
You're welcome.
All right, folks, we're going to go ahead and take a lunch. It's just about 10 to 11. So go ahead and grab lunch, whatever suits you, and we'll be back around 12:30. See you then.